Imagine this. A young patient is in your clinic with blinding headaches. The pressure inside their skull is so high it's threatening their vision, and the next step on the table is risky surgery. But what if the key to saving their sight isn't what we've all been taught? For decades, the playbook for idiopathic intracranial hypertension, or IIH, has been all about one thing: weight. But what if there's a completely different mechanism at play? One that could totally change how we manage this devastating condition? This really boils down to two huge clinical questions. First is the incredible benefit we're starting to see with GLP-1 agonists in IIH, just a happy accident of the pounds lost. And second, could these drugs actually be working directly on the brain to lower pressure completely separate from any metabolic effects? Those are the exact questions we're tackling today. Okay, so to really appreciate just how groundbreaking these new findings are, we have to quickly run through the conventional playbook for managing IIH. For as long as we've been treating IIH, it's been tightly, almost exclusively, linked to obesity. And that has made weight reduction the absolute cornerstone of therapy. It's been the critical target we aim for to relieve that pressure and, most importantly, preserve vision. The problem is, this standard approach has some real limitations. Acetazolamide, our first-line drug, has side effects that are so bad that nearly 1 in 5 patients just stops taking it. The next step, surgery, well, that comes with its own serious risks. All the while, the weight loss goals are incredibly tough. Sure, a 6% drop might help the papillema, but for a real lasting remission, you're often looking at a 15% weight loss. That is a very high bar for our patients to clear. But now there's a major twist in the evidence, and it comes from a 2026 meta-analysis that was published in the Journal of the Neurological Sciences. And just a heads up, all the links to the bibliography are right there in the description below. And this was not some small-time study. This analysis pulled together data from 9 different studies covering a massive cohort of over 13,000 patients with IIH. That's a lot of data. So let's see what they found. First off, a really powerful clinical outcome. Patients who were treated with GLP-1 agonists saw a 24% reduction in the risk of their disease getting so bad that they needed surgery, like a shunt or a stent. Even more important is this: these drugs cut the risk of vision getting worse or even leading to permanent blindness by almost half, a 49% reduction. That is an absolutely practice-changing number for the one complication our patients fear the most. And then there's this, which is just astounding: an 80% reduction in the risk of mortality compared to conventional management. So let's be clear. These drugs aren't just improving symptoms, they are saving lives and preventing truly catastrophic outcomes. And here it is. This is the slide that changes everything. What's so amazing here is this forest plot for body mass index. All those incredible benefits we just saw, less surgery, less vision loss, way lower mortality, all of that happened with no statistically significant difference in BMI reduction between the GLP-1 groups and the control groups. Let that sink in for a second. This tells us loud and clear that something else is going on here. This discovery forces us to look beyond the scale and ask the real question: what is the actual mechanism at play? Well, the study's authors point directly to a new mechanism. They state that the benefit is likely coming from a decrease in cerebrospinal fluid, or CSF, secretion. And this happens because the drug is acting on GLP-1 receptors located right on the choroid plexus, the very structure in the brain that actually produces CSF. I love this analogy. Think of it as a Trojan horse effect. For years, we've been focused on the horse itself, the weight loss, but the real power, the real weapon, is the soldiers hidden inside: a direct, rapid, and weight-independent effect on CSF production. This diagram basically shows how the drug gets in there and inhibits a key pump in the choroid plexus, directly turning down the faucet on CSF production, which in turn brings down that dangerous intracranial pressure. So what do we do with this information? How does this change things in the clinic? Let's approach this like a journal club. We'll look at the strengths, we'll look at the weaknesses, and then we'll pull out some really concrete, actionable points. Okay, so the study's strengths are pretty clear. A huge patient cohort, over 13,000. A really consistent positive effect across multiple important outcomes and endpoints that actually matter to patients, like avoiding surgery and going blind. But we also have to be critical. Most of the included studies, 7 out of the 9, were observational, so there's a potential for bias. There was also some high statistical noise or heterogeneity for some outcomes. And, importantly, there wasn't a lot of direct intracranial pressure data to absolutely confirm the mechanism. So, all this evidence gives us 3 really clear, actionable takeaways for our practice. Number 1, reframe the goal. The primary benefit here may have nothing to do with hitting a specific number on the scale. Number 2, counsel your patients on this dual mechanism. Let them know that their headaches and vision might get better before they see a big change in their weight. This is key for managing expectations. And 3, leverage these drugs to avoid surgery. A 24% drop in refractory disease is a powerful new tool in our arsenal. So if you remember one thing from this entire explainer, let it be this simple phrase. When you're thinking about GLP-1 agonists for IIH, think plexus, not pounds. It's actually a great way to start a conversation with a colleague about this new evidence. All right, let's sum it all up. GLP-1 agonists dramatically reduce the risk of the worst outcomes in IIH: vision loss, surgery, and even death. This benefit seems to be happening largely independent of weight loss, and the likely mechanism is a direct effect on CSF production at the choroid plexus. Put it all together, and this evidence really does signal a genuine paradigm shift in how we manage this tough condition. And that leaves us with a final question to think about in our own practices, really a call to action. After seeing this evidence of a weight-independent mechanism, how will this change the way you select and counsel your very next patient with idiopathic intracranial hypertension? For a full list of our sources and the usual disclaimer, please take a look at the description below.